Good to see everybody trickling in. Welcome, welcome. It's definitely going to be hands-on and engaging, so hopefully it's not too late in the night, but it is for some folks. I see Chinmay coming from Bhavnagar, India. Definitely quite late in the night, but welcome. Happy to have you here. Trish over on the other end of the world, bright and early Monday morning, no? And some other folks in the evening time. Mohammed, welcome, welcome from Qatar. So apologize, I don't know where everyone is from, but definitely over the course of IPSS and working with people, I've gotten to meet folks from a lot of parts of the world and really excited to have everybody here. And I think,
all right, I think, yeah, we're gonna go ahead and get started and be respectful of your time. Thank you again for joining us for this last session of IPSS. I hope you've all had a great time so far. My name is Dennis Wren. I am a pediatric emergency medicine fellow at Children's National in Washington, D.C. And I have the privilege of working with such an awesome team here that I will have introduce themselves very shortly. But welcome once again. For the sake of the experience for you guys, this session is best done on a computer or a laptop so that you guys can actually have the ability to participate in our virtual simulation. And we've also found that this platform tends to run better on Chrome or Firefox as opposed to the Internet Explorer. With that being said, I'm going to turn it over to Dr. Fuhi and the rest of the team to introduce themselves, and we will get started.
Hi everyone, I'm Sarah. I'm a community emerge doctor in Ontario, Canada, affiliated with University of Toronto and soon to be Queen's University. And we're very excited to show you the VRR today.
I'm Brian. I'm one of Dennis's colleagues. I'm also a third-year pediatric emergency medicine fellow at Children's National.
Hi there, I'm James. I'm a pediatric emergency medicine physician attending. I'm at McMaster Children's Hospital in Hamilton, Ontario, Canada. I'm the director of SIM for our division and one of the leads in our region for simulation education.
You've heard from me already, so I'm not going to talk again.
Hi guys, I'm Sam. I'm one of the PEM attendings at Children's National, and I co-direct the resident and medical student education in our division.
And I'm Pavan Zaveri, pediatric emergency medicine, also at Children's National in Washington, D.C., and also the medical director of our simulation program for the hospital.
Awesome. All right. So getting started, we have nothing to disclose. And our objectives for this particular workshop is to describe the techniques for incorporating communication and teamwork into telesims, and we'll show you how to use Google Slides and any teleconferencing software to deliver an interactive and interprofessional telesim, and then hopefully also facilitate a telesimulation with this method.
Great. So as you guys know, in the course of the past 18 months, we have had a forced switch over from the traditional sim that we're all used to and love teaching into a virtual environment thanks to the COVID pandemic.
And for us as simulators, I think this posed a significant challenge. I think we have all experienced that at this point. If we were at one of the earlier sessions on telesimulation, Isabel Gross mentioned that up to 70% of us switched over to virtual simulation methods during the last year or so. And the challenge that lay before us was essentially one where when we had in-person simulation where we were used to, for example, center-based or in situ simulation, we now had to all be physically distanced and be simulating in different locations. And there's many different terms for this, I think, in the literature. There's the telesimulation, distant simulation, remote simulation. I don't think we as a community have come together as a consensus about what those terms are. So specifically, I think for this this conference or this workshop, we'll use those terms interchangeably. When it comes to these sort of distance simulation methods, what lay before us at the beginning of the pandemic and what's emerged throughout the pandemic are these sort of the single learner type of interactive experiences. So either virtual reality, augmented reality, or serious gaming. And the other sort of form that really became popular are these sort of online or teleconference versions of sims. And when we talk about sort of these single player virtual augmented realities, these are very often simulated virtual patients that are pre-programmed to act in a certain way. There's also a number of choose your own adventure stories, which include websites or apps that are usually performed asynchronously without a facilitator available. And the other modality that became a lot more popular is the use of teleconference. There's one of the forms that became very popular we call marionette simulation, in which we had educators in the lab that are sort of your hands doing your actions, while the participants were often at distance providing instructions to those educators. And the other finally form that emerged is these sort of facilitated guided screen shares. And with the pre-existing options, some of the limits that we found primarily dealt with implementation and cost. A number of the methods were very expensive for learners and required a lot of hardware upgrades that weren't necessarily available for everyone or easy to pick up. And at the same time for facilitators, in terms of getting used to having to deal with development times of scenarios, or developers to actually write out scenarios or pre-program things. And overall, it challenged the simulation experience because rather than sort of our normal task of listening and speaking, we weren't really able to do things by hands. And because we weren't able to do things, we weren't really able to practice our CRM skills. And ultimately, the challenges that lay before us ultimately affected how we debriefed afterwards.
So just to talk a little bit about our evolution at Children's National when the pandemic hit to where we are now, we started with just doing simulations via Zoom, and we'd put on virtual backgrounds to demonstrate physical exam findings or EKGs. We transitioned over to kind of a choose your own adventure interactive PowerPoint presentation before finally transitioning over to the virtual recess room, which we have loved and really incorporated into our didactics.
I'll tell you a little bit more about the virtual recess room. The concept is very simple. Really, there's two kind of forms of virtual connection. The first is Zoom, where people can see each other and talk to each other, just like we're doing now. And pretty much all online simulations have required Zoom or the use of another teleconferencing software in some way. The novel part about the virtual recess room that hasn't been used in other areas is the use of Google Slides. So we all know Google Slides is essentially like an online PowerPoint. Most of the time people use it to do PowerPoint presentations, and it's used by university students because multiple team members can simultaneously edit. So essentially the virtual recess room takes advantage of the fact that you can do synchronous simultaneous edits to allow learners to interact in the same virtual environment. So it's a set of slides that look like a recess room and have all the equipment and meds you need to run a sim, where people can be at the same time making changes and edits. It makes a little bit more sense when we show you this in action. So first, James is going to tell you about how we've used the VRR, and then we're going to give you a demo about it. So you will see how it works.
So I also want to acknowledge that there are a number of people that are actually participating in this workshop today that have used the VRR already for pediatric uses. So thank you so much for everyone that's been interested in using the VRR for that purpose. As an overall summary, the VRR, we have used it for a number of populations that ranges from medical students to very senior staff and faculty, and also our interprofessional colleagues and allied healthcare providers. And we used it in a number of contexts that ranges from replacement of in-person simulation, especially during the COVID pandemic, but also the introduction of new simulation curricula. Dr. Burns, Becca Burns, presented on the EM Rescue curriculum, and we've used the VRR in terms of teaching that curriculum to a group of emergency medicine residents during the pandemic. Also been used for outreach education, interprofessional education, education for international learners, and also for continuing practice development purposes. And a number of cases have been created for virtual resuscitation rooms that deal with pediatrics. A number of them have also been shared by a growing community on the Virtual Recess Room website.
So the first group of students who we ran the virtual recess room in a formal way last summer at McMaster, we used it to do this paper, which has recently been published, which essentially showed that for the med students and the facilitators who are involved with our ACLS-based curriculum for their clerkship, had endorsed very high scores for these factors you can see listed here: usability, applicability, fidelity, knowledge acquisition, and decreased time investment for the facilitators. So we'd received a lot of kind of positive qualitative feedback and positive feedback in the sense of uptake, but it was very useful to have kind of some statistical proof that this is an effective learning tool. In Canada, we've used it since that initial project, really all across the country, for adult and pediatric emerge, and for kind of in situ kind of based replacements, as well as interest group activities, particularly for medical students. And I believe there's more than 30 cases posted now kind of for adults and peds combined.
Likewise, here at Children's National, we've been using it for a variety of trainees, from our medical students to our residents, fellows, and nurses. During the pandemic, we had replaced our in-person interprofessional sims, which happened on a weekly basis with the same, just virtually instead, using many of the similar cases that you guys already heard about from James. The evaluations from our learners have shown that they enjoyed these simulations. They felt like the difficulty, the challenge of completing them was just about right, and that their experience with the simulations were between good and excellent. And you can see the comments here that people felt more comfortable and felt like this seemed like a reasonable representation of what the simulation might feel like in person.
And as you can see here, the virtual resource room has been used all over the world. It's been used for local groups, but more recently, it's been used for kind of bridging education between providers who work in different centers in different countries. And I think that's really where the future of the VRR holds. So I'm hoping for you guys that are attending today, you can look and think, how can we use this modality to connect educators who work in academic and rural sites in between different countries?
So with that being said, we are going to transition actually into our demo of how the VRR works. And then shortly afterwards, we'll go into our breakout rooms. We'll have you guys go through another VRR and actually facilitate a VRR as well before coming back and having a discussion as a group.
There are two options for how you guys can participate in this demo. You can join the Google Slide link, which we're going to put in the chat, and just watch what we're doing by navigating through the slides yourself. Or you can simply watch on the screen share if you'd rather kind of see how we're interacting with it the first time. You'll have plenty of time to play around with the slide set when we do breakout rooms.
All right, so James has dropped the link into the Google Doc. And so again, you are welcome to join us on that, or you can view the screen share. The beauty of this is that you do not have to be on a screen share while you are using the VRR. But I will have Sarah give the intro to this case as people are coming into the virtual recess room.
All right, so I'm going to act as the facilitator for this case. So I'll play the role that many of you guys will play if and when you use the VRR. So team, who is going to be my team lead for this case?
I'll be your team lead.
Okay, so Brian, you have a 5-year-old girl who's come into the emergency department. She's been feeling very unwell with upper respiratory tract symptoms, no past medical history, no medications. The nurse felt she looked quite unwell, so she's been brought directly to a recess room. No vitals yet.
All right, and so it looks like I have a good team with me. So, you know, James and Airwave, we can get her on some oxygen, and it's I think Dennis who is, or my bedside nurse, we can get her on a monitor so we can see what those vitals are. And generally, how is she looking when I see her?
She looks well, like her color is good and she's kind of crying and able to answer questions, but she's definitely not herself. Like she's crying and quite fussy compared to usual.
Okay, and then are parents around? Can I get a quick history of what's been going on?
Yeah, her mom's at the bedside. It started just seeming like a normal cough and cold, but then this morning she seemed really off, more tired than usual. And that's why they decided to bring her in.
Okay, all right. So, wow, seems like a pretty fast heart rate. And then do we have any physical exam findings we can see?
Her airway is patent. There's no work of breathing. Her cap refill is normal.
Okay. All right, and so we can get an EKG. Things I would worry about that is whether that's SVT or she's so sick if this is sepsis.
What's
So
the
we can-
cap refill like?
At the moment, her cap refill is normal.
And they have a pulse, obviously.
Yep, if you'd like to see the ECG, you can proceed to slide 4. And she does have a pulse.
Excellent. If we can get working on an IV, if that's not going at the moment. So to me, the EKG, again, we see like a narrow complex tachycardia. I do not see any P wave. So I believe this is SVT. You mentioned she has a good cap refill and she's mentating, so it's a stable SVT. The first step would be adenosine. So do we have an IV in yet?
I'm trying to obtain one in the right anacube. Did you want me to draw any labs on doing that?
Yeah, we can draw a gas, basic chemistries, CBC. And then do we have a weight on her?
Mom's not sure what her most recent weight was. She's 5 years old.
Okay. We can use the Braslo if we have it, or you can use our center's weight. 20 kilos is fine.
And I'll get some airway equipment just in case.
Perfect, that'd be great.
I'm bringing the Braslau tape over from slide 2 into slide 1.
Excellent. Thanks, Sam. Wonderful. Getting all the airway equipment, great. So yeah, let me know when we have an IV access and a weight, and we can draw up some adenosine to give to her, as well as we get some working on some fluids.
Looks like the Braslau tape says we should use a 20 kilo estimated weight. And I have IV access in the right anacube.
All right, so we can start with, we can give it adenosine via 3-way stopcock. Keep her on the telemetry.
I have your airway equipment ready.
Perfect.
I'm looking for the adenosine. Give me 1 second.
Adenosine is on the 3rd row. Yeah, there you go.
And is there any updates on how the patient's looking? How's the breathing? And is there
No
any
change in critical status.
So again, we have a 5-year-old who is coming in, what looks like to be stable SVT, has a good cap refill, is mentating well, but has a bit of a soft blood pressure. We're preparing adenosine for cardioversion. We have a backup airway equipment ready. And then I guess also while we're getting things prepared, we can also get our Zoll or defibrillator ready as well, just in case this doesn't go well.
I'll apply some of the pads on. I was
Thank
thinking that too.
Okay, your adenosine is drawn up, so just let me know when you want me to give it.
Okay, I'm ready to give whenever you are. We can give now.
Okay, give me adenosine at 4:21 p.m.
Okay. All right. So adenosine has been given. And it looks like, if anything, our blood pressure has gone down. And how's the patient looking at the moment?
She looks more lethargic than she did previously. And if you check her cap refill, there's been a change. You can go to slide 5 to see if her physical exam.
All right, so she has pretty prolonged cap refill. So with that change or decreasing blood pressure, I think we've switched over into unstable SVT. She's already on the Zoll. If we can prepare to cardioverter her.
Would you like any medications to sedate her while cardioverting?
Sure, we can draw up some ketamine would be fine.
You can proceed to slide 6 to operate the Zoll.
Okay. All right, and then so we said that her weight is 20 kilos. Is that correct?
That's correct.
Yes.
All right, so then I'm going to move. I'm going to put my sync on, and I'll so I can type. There we go. So we can do that's like 0.5 joules per kilo. Is that correct?
Correct.
Yes, that'll be the basic dose.
So we will put that in. We will have. I'll move over here to move my hand over to the sync button so we can sync. Yeah, that too. Cool. And so I'll move my hand over to the charge button. I'll move over that. I'll charge. All right, and so can we are we all clear, including oxygen?
Let me take the oxygen off.
And I haven't given the ketamine yet. Did you want me to go ahead and give it now?
Sure, that'd be great. Thank you.
All right, I'm slowly pushing ketamine.
Okay.
Oxygen is off.
All right.
She seems sedated and she's had nystagmus. She's responded to the ketamine.
Excellent. And so she is sedated. Oxygen is clear. I'm clear. Are we all clear?
All clear.
Okay, so I'm going to go over here. I'm going to hit the shock. All right. And then can we check a pulse?
She has a pulse.
Great. And so now what I'd want to do is we can talk to cardiology. We can keep her on some oxygen, James, as she recovers from sedation. And obviously the other things I would do too, for the sake of time. We have not gotten her, it looks like, to a sinus rhythm, and we'll talk to cardiology, likely admit her.
Okay, so we'll pause the case there. Thank you, team. All right, so that's our demo of how it works. I know sometimes when you're watching, it's not entirely clear exactly how everyone is doing the motions. So that's why we want to spend most of the session in the breakout room so you can play with it and get the sense of what I was doing as the facilitator, but also what our participants were doing. Any immediate questions before we divide into the breakout rooms or first thoughts?
I have a question about just orientation, if seeing this for the first time. What's the pre-brief like? How extensive does it have to be so people just don't go rogue? This is very, very organized.
We do a two-part pre-brief. So the first is we send an email out with the VRR website where there's a demo room where people can just play with it and some videos as well as written instructions. I would say it's like 50% of people read the instructions. So day of sim, we always do a 15-minute intro as well. Today we just jumped in because we wanted you guys to see it in action, but usually it's like our intro is very much like, go to slide 2. This is where we keep our meds. You get meds by copying. So we're like very elaborate of how it works with copying and pasting and even minimizing and maximizing the screen so you can see Zoom and the Google slide at the same time. So when we go into our breakout rooms, we'll do a little bit with that with you guys as well, so you can see what our usual orientation is. The long story short, it usually only takes 15 minutes or less, and then people can kind of catch on as they go.
All right, so with that being said, I'm going to stop share for now, and we are going to break out into our small groups so we can actually give this a shot. For the sake of the small group experience, again, just please turn on your audio, your video, so we can see your wonderful faces and hear your voices. And then if hopefully you guys are on like a laptop or a computer for the best experience.
Awesome. Welcome back, everybody.
We were stolen from our room right in the middle of
Yeah, we were like, what? What happened?
I don't know what the blood sugar is.
Our room adequately resuscitated the patient. So well done. So in these last couple minutes, we were initially going to talk about some of the ongoing projects with VR, but I do think that we want to make sure that we have some time for like a Q&A and a discussion with you guys to see, how people envision using the VRR, if you're using the VRR already, and anything that we can potentially answer for you or hope to answer. So it's an open floor here.
And we're a small enough group, just feel free to unmute yourself and speak up.
Just have a question. It seems like this is a great opportunity to use at a basic level for medical students, at least for me right now. But just wondering about what work has been done at a higher level, say team training, interprofessional training. In our institution, we kind of, because we are a small group, we were able to do in-person simulations, like for trauma and COVID-related scenarios, but just wondering what others' experiences doing at a higher level using this platform.
So I can say, sorry, Sam, if you wanted to chat about like our we've been using this for residents, so rotating residents from emergency medicine, family medicine, our pediatric residents, in addition to the medical students. And we have made an attempt to make it as interprofessional as possible. So when we were running these simulations, we had included nursing orientees. And so we really wanted to drive home that interprofessional and communication aspect of this. And I think you were in my group, but I did my best to try to demonstrate that as well with like our closed loop communication of, double checking, is the dosage correct that you had ordered? And then also closing the loop when I said, okay, the ceftriaxone that you had ordered is now given. And so those are all habits that, we hope that we see in those interprofessional team dynamics.
I can speak a little bit about some of the other audiences as well. We've been working with the impacts group as well, that Mark Arbach has been working and looking at pediatric readiness. It's been used for some continuing education settings. So for some outreach education of staff providers. Sarah and I had the chance of adapting the VRR for the virtual TRIC course, or the Trauma Resuscitation in Kids course, that the Royal College of Physicians and Surgeons of Canada has put on as well too. Sarah and I are just actually about to do a bit of a trial in the next week. We've been working on this for doing this for outreach education. So between Hamilton and Toronto and some colleagues at SickKids, we have 14 community hospitals that have signed up with interprofessional teams. And we have some cases based off of the TREC guidelines that we've created and their assessments in terms of using them to educate that. So some data and studies going to be coming up for that. We've also, again, similarly used it for education of the rescue curriculum that Alium has posted. That was trialed with the McGill group and also with a group out of Yale. I'm in the process of analyzing the data right now, but the data for that in terms of the acceptability, the learning has been very, very high right now.
This is very similar to NRP 7th edition e-simulation cases, where you have, a test to do multiple choice questions. And then once you pass that, you do an e-simulation, and you have to pass the e-simulation. And then after that, the next step is live simulation. Is your hospital using this as a stepwise approach where you first teach the concepts and then go through this process of the virtual simulation, and then the next step is a live simulation?
We haven't used that at either of our sites, but I know that has been used by places. So I know there's been some nurse educators in the States who've used it for the perimortem hysterotomy, where they talk about it, then they do the VRR sim about it. But then obviously, because it's quite expensive doing inter-D sim for those OB cases, then they do in-person sim for people who are interested. It's been used to supplement as well for the cases that are a little bit harder and more expensive in some of our local sites. So they do the sims that they can in person, but this way you can add like an extra 4 or 5 sims pretty easily to a curriculum. So instead of having 2 sims in a 2-month block, you can suddenly have one every week.
We have time for about 1 or 2 more questions before the end of our session. So.
I'm interested in having a larger group, like you can only have so many roles in the resus room. How do you manage a bigger group, and do you have set rules for observers, and or do you involve them in a decision-making process, or how do you manage that basically?
Trish, that's a great question. Sometimes our learner groups are larger than say like 5 or 6, which I think is ideal for example, resuscitation. When that is the case, I do have my learners have what we call research experts. So when there are questions about things like, what is the dose or what is the next best therapy, there are people who are behind the scenes looking up what to do and dropping items in the chat for suggestions. So they're not vocal members of the team, but we're doing our best to keep them engaged so that they can give us feedback as well at the end of the session.
Oh, that's a really good idea. And it's good to know that 5 to 6 is your ideal group size as well. Same as any recess, I suppose.
Yeah, I would say parallel to the in-person sims.
And would you have like if you're in the ED, would you have an intensivist that you could actually have to actually come in from that group, from that expert group to contribute to care at all, or to talk to?
Not necessarily. Yeah. Usually we'll have, for example, a senior resident fill that role. So we'll have an intern be the team leader. And then I've sort of everyone step up a role and have the senior resident come in and take a sign out so they can practice their verbal communication skills as well and to offer additional suggestions.
We'll
There's also
sometimes have
options.
it be where one of the content experts acts as like they would act in the real life. So if you have like James, who's a pediatric emerge doctor, as the facilitator, he can answer the phone call and pretend he's also the consulting pediatrician. So we just kind of use the skill set of who we have as facilitators present to kind of simulate that. And we do that 2 ways. One is by muting and then doing real phone calls, or you can do WhatsApp conversations to do kind of sidebar conversations, which forces a summary statement when you finish your consultant phone call.
We've also had the chance of using it for communication. So we'll actually sometimes have a second breakout room where one of the participants can actually get information from the parent, and we'll have to report back to the group, similar to in real life where you have another side conversation simulated off in the distance. And we use breakout rooms for that addition.
I think the kind of takeaway point is that it's Google Slides, which most of us are pretty comfortable with, and you don't need to be a tech expert to make your own slides. So you can tailor it to suit your resources, your group, your teachers, and it's pretty easy to modify.
So I think that unfortunately concludes our time for this session. Thank you all very much. I dropped 2 links in there, one to the just virtual recess room main site, and also to the building blocks as this amazing product that Sarah has created, really allows for a lot of flexibility, creativity that I think you can adapt in multiple settings. And so hopefully this has piqued some interest, and you guys will play around with it. But any of us, I think, is more than happy to connect offline and chat more if you guys would like. But thank you again for coming to this session and the workshop. And I have to say thank you to all of the collaborators here. We love working with such an international group on a project like this.